Yes, I'm also happy to be with you, and this time not for injectables or for peeling, but for surgery. And I do a lot of surgery in my private clinic. And because I'm not as Dr. Turki is not in the hospital, there are some differences. I try to, yes. So when we talk about surgery, I think we also have to talk about beauty. And some of you would ask yourself, is this really possible to have surgery on beauty? And of course, but the results are always multifactorial. And if you want to do a nice surgery, then the way for the success is quite long. We all, and with right, we talk about the surgery itself, the skills, the different technique. But what we forget a little bit is the preparation, also the pre-operation time and the aftercare, which is also very, very important to have nice results. Because surgery sometimes can bring surprises, and these surprises are actually never to your fun. So we have to be careful when we do this in the private clinic and not in a hospital setting. So it is very important that when you do surgery and bigger flaps in your private clinic, that you have reserved decision. What do I do when what happened? So then you will save time for one thing, or when you really have a bigger complication, you save at least big complications afterwards. When you begin, when you have before the treatment, you have to talk to your patient and you have to explain the patient everything which is interesting for him. So the first question is, does it hurt? The second question, does it scar? And how will the scar be? Do I have some alternatives? Are there side effects or complications? In other words, you have to build up a bond of trust. And then when you have this, the patients will follow you, even if you have complications. So don't forget, each information before the surgery is a clarification. When you do the same information after surgery, it is an excuse. And who wants to excuse himself? So in other words, destroy the fears of the patient. And when you get that, when you get there, then you will be successful. This is the hospital setting, only the technical part, but when this room is filled for the operation, it is also filled with helpers, with anesthesiologists, with nurses, with several doctors. And this is the setting sometimes in your private clinic. And there, all the conditions are completely different. So you have limited equipment, and sometimes it's a little bit improvised, the setting. Your staff may be excellent on the reception, but when she helps you doing surgery, it can be that she's not that trained. Sterile surgery, this is a very, very big theme, big topic, sorry, and it is simply not feasible. We do not have the staff to be completely sterile. We do not have all the technical possibilities. So the limited sources there are also limited sources for aftercare. So it gets actually a little bit more complicated, and we should prepare to avoid such situation. And I always say planning is half the battle. If you do know exactly what you want to do, you will be planning this, you will be during the surgery, you will do a good job. And even if something occurs which you didn't expect, then you know what to do. So my operations theater in the private clinic is simple equipped and functional. Like this, I have very, very little mistake, sources for mistakes. Everything is on where it should be, and my assistants know where the things is. In my experience, it's very, very helpful if you plan one surgery day in the week. It is good for you because you are in a flow. It is good for your assistants, for your staff, because they know everything what they have to do. And it is also good for the patients. He meets somebody else in the waiting room having a nose surgery, and they talk that the other one has an ear surgery. So this also is good for your practice, for your clinic. It improves your better reputation. A word for the sterility. Do we need it? Of course we need it. I'm not here and saying you do not have to operate sterile, but in the private clinic it is very difficult, and there are many of surveys which show that most affections are made by the mode of surgery, how much you traumatize the skin, the tissue, and the duration of the surgery. But again, we have to operate clean and probably not that sterile that we would expect in a hospital setting. So we always cover our patients correctly. They are always disinfected correctly. Of course, we do have a lot of sterilization. And for things we touch a lot, we have simple solutions. These are sterile hand gloves, which we put over the handle so that also the surgeon itself can move the lamp. A word to the anesthesia. It is actually for the patient the most dramatic part of the whole operation, and that's why he's interesting. And there it is very important that you are as little hurtful as possible. So we need 30 gauge needle, and we buffer our lidocaine with bicarbonate that it doesn't burn that much. And if you inject according to skin cleavage lines, this is a big help that it doesn't burn too much when you inject. A little trick which I always use is it goes in the same direction. I stretch the skin and inject very slowly with a body warm anestheticum, and this helps really to reduce the injection pain. When I want to be sure that the anesthesia is complete, so I do a blanching or superficial, and then I always go in the subcutaneous deep area to make sure that the anesthesia also works. These are my instruments for success. Mostly it goes with only these tools, different scissors, scalpel holder, and pin holder. But I have another package for when it gets a little bit more complicated. There is a wound retractor in it, different forceps, and different clamps. And this is mainly my instrument plan. And with this, I do all these operations I will show you afterwards. After you did your extremely good surgery, you have to do a wound dressing, and the wound dressing has two things. It has to reduce the tension, and it has to look nice, because if this looks nice, the patient thinks that the surgery was very good. If it looks a little bit shabby, then he might think that also the surgery was a little bit less professional. I use always a folio like this, keep it 1 week, like this, the patients can do shower and everything, and after 1 week I take the stitches. 2 words for biopsy. We have different punches, and this is how I do it. I stretch the skin against perpendicular to the cleavage, and then I do my biopsy, and like this I have an oval shape of the wound, so I can suture it without having any dog ears. This is a nice little trick that you do not have any dog ears. Again, the dressing is very, very important. Tension is actually everything. I do large excision, wide wounds. I do 2 layers sutures to reduce the tension. I think the tension, if is no tension in the suture, then it brings a better outcome, or the other way around, a suspenseful outcome. A word for taking the stitches. we always learn that we have to have the stitches 2 weeks. If you look at this diagram, then you see that between 7 and 14 days, there is not a big difference. The really tensile strength of a scar is 6 to 8 weeks, and nobody would leave it 6 to 8 weeks. That's why I take it one after 1 week, and then I do a Steri-Strip dressing. I always here, I do a nice scar and I take very little. If you do this, then again, it is a tension. You have too much tension. You have the danger of dog ears. So actually, the length of your excision should be 3 times more than the lesion itself. And then you have an angle of the wound of less of 30 degrees, and then you do not have any dog ears. The longer the suture, the better the scarring, and I tell this to the patient beforehand, because they always measure the severity of the surgery by the length of the suture. And if they know I do long suture because I want to have it perfect, then they will be happy. No compromises in surgery. This has to be solved intraoperatively and not afterwards, because there is a mistake in surgery. 2 words for the correct wound structure. We want eversion. That means we have to put the needle vertically and use the whole pronation of the needle, and then we really put up the eversion of the skin, and this gives a much better wound healing than if you just put it together, because the scarring will do the rest. Now I have still 2 minutes, Dominique, for some cases. My thing is KISS. So
take your time. Take your time. We have plenty of time.
Okay. Thank you. Keep it simple and safe. And if you have basal cell carcinoma on the tip here, why not do a primary closure? This patient is actually a patient of aesthetic, and she comes on a regular basis, and you can't see anything after this surgery after 6 weeks already. If it is a little bit more complicated, a little bit bigger, and mainly in elderly people, you can do the bilobed flap. This is the basal cell carcinoma after the anesthesia, and this is the defect. We do a bilobed flap. We remove the skin from the bone and cartilage, and then we skip it into the defect like this. And if you do like this, this is day 7, day 30, and day 60. And after day 60, you really have, in my eyes, actually a very good result. Problem of this flap is that you always have a little bit of tension vertically. That means it can take your eye, your nose lobe a little bit up if you have a little bit tension. Age plastic I like a lot. This is a big keratoacanthoma on the front, and we excise it. Then we do the distal and cranial incision. Then we mobilize it like this, and we close it. This is after 7 days, and after 60 days is you can still see it, but I had the chance to see this patient a year after surgery, and here you nearly can't see anything, and it was quite a big keratoacanthoma. This is something for Dr. Turki. It is a little bit the same like the comma flap. We have, you showed already this case or a similar case. We have quite a big defect, and we do it with a cheek rotation flap, actually in the same manner you did. I think your technique is a little bit better because I need to mobilize more skin than you showed us in your talk. But anyway, if you close it then, and there you have to have some patience, because after day 7 it's looking okay, but after day 30 it's even getting a little bit worse because of the edema. And if you do a lot of massage, you can have nice results. East-west flap, last case, like this. You have the burrow excision triangles, but you do it on 2 sides, not vertically. And then you really can easily get this flap into the wound. And after closing it, you won't see more or less nothing anymore. And because of time, I think I really overdid it. I will stop here, Dominique. That's okay. Thank you very much.
Thank you. Thank you very much, Dr. Creden. It was great and a good complement of previous presentation. Anthony, do you have a question for Dr. Creden?
That was a wonderful presentation. I think that acronym KISS is so important because it's in everything we do. You know, trying to keep it very simple and straightforward not only helps us, but I think helps the patient as well.
Of course.
You know, during COVID, like the height of the COVID pandemic, I was using a lot of dissolving sutures. What's your suture of choice, you know, for these beautiful closures?
I had to, because of time, I had to remove this presentation. I also use dissolving suture. I use Vicryl for the depth, and then I have 5-0, mainly in the face, 5-0 Prolane or Dermato.
Nice. Yeah, I mean, I started to use a lot of that, and I also started to incorporate more running horizontal sutures because I think it gives me more eversion than just sometimes straightforward, you know, regular interrupted sutures.
Okay, yeah.
But I think our techniques are always like evolving as we learn from other people.
Also the plastic surgeon, they do always, how do you call it, when you go on in doing the suture?
Running, yeah.
Running suture. I personally, I don't like it because if I have once a problem, then the whole suture have to open. So yes. I do it stitch by stitch, as you have seen it. It's probably a little bit old-fashioned. Could be, you know. Yeah.
No, but they look beautiful. Yeah, thank you. Let me just check the. Okay, great. Any of our speakers have any questions so far? We're doing well on time.
Yeah, Dr. Cherki, do you have a question as comparing your technique and what Dr. Creden has presented?
Dr. Creden, it's a very beautiful conference, but perhaps the basal cell carcinoma, check I think you have take a large part of the percutaneous. We can do it less perfection like this.
Yeah, I agree. Also, actually, I have to tell you, this case is some years ago, and actually, I was very proud of this result. But when I saw you with the comma flap, I think this is the better way because your excision is much less traumatic.
Thank you. Okay, thank you very much.